Time for yet another clinical toxicology video discussion. The topic today is lithium toxicity, corresponding to Chapter 70 in Goldfrank's Toxicologic Emergencies. The learning objectives for the session are that you'll be able to describe the expected signs and symptoms seen with both acute and chronic lithium toxicity, and to outline the treatment options available to treat lithium toxicity. Therapeutically, lithium is primarily used to treat bipolar affective disorders, which is to say those mental health conditions that can include mania. Much of the early parts of the chapter talk about the history of lithium as a drug and the complex and not yet completely understood mechanisms of how it works. Interesting stuff, but not immediately applicable for our purposes today. Lithium is a metal ion, and it has some unusual pharmacokinetic features. Since it's just a metal ion, it is not metabolized. Basically, it can't be metabolized. It gets absorbed and distributed, and is then filtered in the kidneys and excreted in the urine. And this reliance on renal elimination will come up again later. The figure here says that it's about 95% eliminated by the kidneys, and that's only because some small amount can be eliminated in the feces and in other body fluids. In addition, since we're giving lithium to produce effects in the brain, it has to get into the CNS. And this distribution is quite slow, with a half-life of about 24 hours. This is also going to come back again when we're talking about treating toxicity and how quickly we expect the levels to decrease and for the patient to recover. Lithium also has a low therapeutic index, which is to say the range of lithium levels we want to achieve for therapeutic effect is pretty narrow. Typically, we'd like to get a serum lithium level of about 0.6 to 0.8 millimoles per liter, and maybe a bit higher to treat acute mania, up to about 1 millimole per liter. We would expect to see toxicity with acute overdose at levels just a bit above the upper therapeutic range. And although not shown here, lithium levels getting up above 2 millimoles per liter are where we expect to see some serious toxic effects. But you can also see here that in the absence of an acute overdose, you might also see chronic toxicity at concentrations that basically overlap the entire therapeutic range. Risk factors for developing chronic toxicity include anything that would prevent renal elimination, like renal failure, or conditions where the kidney is trying to hold on to all the sodium and water it can, such as with dehydration or hyponatremia. To the kidney, a lithium ion electrochemically looks a lot like a sodium ion. And in fact, the kidney will unwittingly hold on to the lithium ions even better than sodium, allowing the lithium levels to keep slowly rising. Acute overdose with lithium causes predominantly GI effects, like nausea and vomiting, as would commonly be seen with ingestion of a whole range of metal salts. And then later, as the lithium is being absorbed and distributed into the CNS, we will start seeing neurologic effects. If a patient had an acute lithium overdose, we might consider some GI decontamination methods. For most acute ingestions, we might give activated charcoal, but lithium and other metals do not bind well to activated charcoal. If it was a mixed overdose, charcoal might be used, but if it was only lithium, there's no point. And if there was a rather large ingestion, especially if the lithium was an extended release preparation, we could consider whole bowel irrigation with polyethylene glycol. Another potential option to decrease lithium absorption that is not recommended for routine use would be sodium polystyrene sulfonate, or Kxalate. This is most commonly used to treat hyperkalemia since it exchanges sodium ions for potassium ions. But since lithium ions are so electrochemically similar, it could be used instead to bind up the lithium. So we've already talked about the GI disturbances that can be seen with acute lithium exposure, and most of the other effects are a spectrum of neurotoxicity with worsening effects seen at higher lithium concentrations. The earliest effects include tremor, and then it gets worse with lethargy and coma at serum levels up above 2 millimoles, which is the same as milliequivalents, per liter. And before we get into more treatment options, I wanted to point out the adversarial relationship between the kidneys and lithium. We've already seen that renal insufficiency sets the patient up to develop chronic lithium toxicity, since the amount being eliminated by the kidneys will be limited. So there needs to be good therapeutic drug monitoring for outpatients taking lithium, periodically also checking their renal function. And then there's two effects going the other way. Some patients on lithium chronically will develop a tubulointerstitial nephropathy. So bad kidneys make lithium levels worse, and chronic lithium can make the kidneys worse too. Also, up to 40% of patients started on lithium can develop nephrogenic diabetes insipidus, where the serum sodium level starts rising unexpectedly due to effects on the kidney, as opposed to neurogenic diabetes insipidus that can occur due to altered secretion of antidiuretic hormone, or ADH, from the hypothalamus. Alright, back to acute treatment of lithium toxicity. Since the primary way to get rid of lithium is through the kidneys, treatment relies on supporting or replacing renal elimination. If the patient does not have renal failure, you give plenty of IV fluids containing sodium. This can help reverse dehydration, including the dehydration the patient might have from nausea and vomiting with acute toxicity. Hydrating the patient promotes diuresis, so there's more urine being produced so that more lithium can be eliminated. But in more severe cases, with more profound neurotoxic effects, or if the patient can't make urine, then we are needing to rely on extracorporeal removal, on hemodialysis. It's generally agreed that dialysis or other extracorporeal techniques should be used in severe cases, but it's debatable whether it actually improves clinical outcomes. And there's an interesting thing that you can see with dialysis for lithium toxicity. When you start, the lithium level will, of course, be elevated, and you can dialyze a patient down to a serum lithium level of 0, but you won't see any rapid improvement in neurologic status. This is because, if you remember, the distribution kinetics are so slow. You can clear the entire circulating blood of lithium, but it's still in the CNS causing neurotoxic effects. But about a day later, the patient may now be awake and alert because the lithium is redistributed out of the CNS, and you'll see that their serum lithium level has risen from 0 back up to, say, a therapeutic concentration around 1 millimole per liter. On this slide, I'm showing some pharmacokinetic data from a 1993 study. The patient on the left is kind of a control because they didn't get dialysis, and we see a nearly straight line on a semi-log plot of drug concentration versus time, showing a slow decrease in lithium level over a few days with roughly first-order elimination kinetics. And on the right, we see a patient who had 3 rounds of hemodialysis. Each time, the dialysis markedly lowered the serum lithium level, but it would rebound back as the lithium redistributed. And other than those 3 temporary dips, the overall graph and the time course look about the same as the patient who didn't get dialysis. Alright then, that's my spiel about lithium poisoning. I'll be seeing you around.